So sometimes in addition to protamine, we will give this product called Kcentra that will just help kind of increase the effects of protamine to help stop bleeding. It usually is a weight-based drug, so you do need to know your patient's weight in kilograms so the pharmacy can concentrate it according to your needs.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now it's time to roll back and start the first case.
On today's episode of First Case, we're speaking with Lindsey Joyce, CVOR nurse and content creator for First Case. Lindsey has extensive experience in trauma and in CVOR, and I am really looking forward to learning from her about using blood and using blood products in surgery. We have a lot to learn today.
We really do. And when it happens, it can happen in a blink of an eye, and time is of the essence. So let's soak up all of her knowledge just in case, because you never know when it's going to happen.
Exactly. So don't go anywhere. We'll be right back with Lindsey Joyce.
Hi, I'm Chris Blevins.
And I'm Melanie Perry.
From the studios of Healthcare HQ, you're listening to First Case.
Joining us now is Lindsey Joyce, CVOR nurse extraordinaire and our coworker here at First Case. Lindsey writes many of our blog posts and provides excellent clinical insight for a lot of the things we do here at First Case. So Lindsey, thanks for joining us today.
Thank you guys so much for having me back.
It's good to have you here. It's nice to have all three of us looking at the same screen and being together for this episode. And today we are going to be talking all about blood and blood products and what we use or might use in the operating room. And Lindsey, you really are the perfect guest to discuss this topic. So Lindsey, why don't you go ahead and just introduce yourself to everyone?
All right. So like Melanie said, my name is Lindsey Joyce, and I currently am a CVOR nurse at a hospital in St. Louis, Missouri. Cardiac, thoracic, vascular, endovascular. We do it all. I love it all.
I'm glad you do. I'm so glad you do.
Been in the OR. Somebody's got to love it.
Exactly.
So.
Yes.
Been in the OR for 16 years, done CV for the last 4.5. I've worked in ORs in St. Louis, but I've also worked in Dallas and Houston. And when I'm not working in the CVOR, in the spring every year, I am the coordinator for the perioperative nursing elective for senior nursing students at St. Louis University, trying to bring our soon-to-be newbie nurses and expose them to the OR and get them into the OR. And then, like Melanie said, I saved the best for last. I am also a content creator for First Case. So for the blog and the social medias and the podcast and
all the things.
Yes.
All the things.
Yes, we milk you for all of your expertise on a regular basis. But so Lindsey, actually, you mentioned your perioperative nursing elective that you teach. That's actually what brought you into the First Case clutches in the first place, was you reaching out to me to be like, hey, do you want to talk about the perioperative nursing elective that we teach? And I'm like, oh, heck yeah, we want to talk about that. So for all of you
I never expected Melanie to actually reply back. I just assumed it would go unread or they would say, no, that's not interesting enough. So I was very delighted when she said, absolutely, yes, let's talk about it.
So if you want to go back, anyone listening, and hear more about Lindsey's perioperative nursing elective, that is back in our archives. You can find other content that we have interviewed Lindsey about and just learn more about her and what she does. But also, as we're talking about learning more about you, you also have some very interesting hobbies. What else do you do besides all of the OR nursey things you just mentioned?
Well, what's kind of nice is when I am not at work, I can do the other OR nursing things while I'm engaging in one of my favorite hobbies, which is travel. And I am pretty much If I'm not on call for the weekend, I'm probably off somewhere in some adventure. So I'm out of town for sure. But I also I kind of have a little side hobby at home, doing my own little mixology cocktail experimentation. And I enjoy, my friend and I do supper club, where we go and find places in the St. Louis area neither one of us have ever been, and just try something new twice a month.
That's fun. That's a lot of fun. And so also, Chris, Lindsey and I are also we serve in the AOR and E chapter together, and we have enlisted Lindsey to be our cocktail mixologist, hopefully at Expo next year when we get the E chapter together in person, and maybe we can have some drinks that are, E chapter branded or something. OR related, whatever.
I put one together last year where it was champagne and blue carousel and called it Blue Wrap Beauty.
Yeah, it was great, but we didn't have enough time
to get
the catering people to coordinate with us. So we're planning for next year though. So any E-chapter people listening, come join us next year.
It's ready. Yeah, that's the most important role, I think, in the entire E-chapter.
For anybody in perioperative services, I think we can all agree that this is a primary function here. So.
Yeah, your membership just increased tenfold.
People want to join.
You can edit this part out, but I'm not the social coordinator for the team for a reason.
You are now.
I'm always planning the lunches and the happy hours and the dinners, and that is like a primary role that my boss has actually put in. How well I do that in my evaluation.
Well, I hope you get reimbursed and it works in terms of your compensation. But okay, so we need to. We don't get together often enough, as evidenced by our conversation already. But we do want to actually provide more education today than just how to mix drinks and be social. So let's talk about blood products and the blood products that we would use or might need to get in the OR and use. And I kind of want to take a step back and let's look at the history of that in patient care. So where do we start seeing blood or blood being used when we look back at the history of surgery?
So I think when you think about the history of blood, the first thing that probably comes to people's minds is bloodletting. And that has gone back for ages and ages, well before even the first recorded bloodletting procedure. However, the first recorded blood transfusion that has been documented in science history was actually back in 1665, but it was not a human blood transfusion. It actually was a transfusion between two dogs.
Oh, no kidding.
Dr. Richard Lauer, he had one really sick dog, and he had one well dog, and he was trying to keep the sick one alive. So he took blood from the well dog, transfused it into the sick dog, and on record, that is the first transfusion between two species. And my understanding is the dog did well.
That was my next question. Did the dog survive?
That's all it said was the dog, the dog was alive. That's the last I was able to.
Man's best friend.
Exactly.
Good grief.
Wow.
Yes. Yeah. My golden doodle is going to be very surprised. She thinks she has a hard life now. Be like, you have no idea what I've never put you through.
And then the first recorded human blood transfusion on record can date back to 1818 when Dr. James Blundell, he was an OB at the time, he performed the first successful transfusion of human blood to a patient to actually treat postpartum hemorrhage.
Really?
Wow.
Yeah.
Well, was there an understanding about blood types back then and to know if it was okay for whose blood to get, for who to get? Hold on. How do I say that? Did they understand how to give blood to people safely?
Not back then. No, blood typing didn't come till much later. But at the time, it was the only thing that they thought, they're losing blood, so the solution is to give blood.
Right.
Which makes sense.
Yeah.
So it's a crapshoot, right? You just
let's hope it works.
You got lucky if someone had a compatible blood type and they just so happened to be available for, transfusion, if you will.
So then you fast forward, you talk about blood typing, you fast forward to 1907, and we have Dr. Ludwig Hechtken. I hope I'm pronouncing his name right. I'm sorry if I mispronounced it.
I don't think he'll mind.
He probably won't. That's when he started looking into the safety of blood transfusion and doing more testing and realizing that blood types can look like different cells under the microscope, and then they can find the antigens or if they don't have antigens. So that's when he kind of got a little more into the safety of blood transfusion. And actually later in 1907, he performed the first human transfusion with proper type and crossing and antigens.
Yeah. Well, thank goodness for that then.
Yeah, I'm glad we figured that out.
Oh, yes. It has saved a lot of people over the years by getting properly matched blood.
Right. And so back in the day, they used leeches, right? For the bloodletting procedures, if I remember correctly.
Yep.
Yeah.
So leeches actually still can be used today. They're not necessarily used for bloodletting procedures. You actually see those more now in wound care to kind of help stimulate the blood flow. They kind of eat the dead bacteria and kind of helps get good blood flow going.
So it's a IND. Yeah.
Well, if you want to just hear something absolutely just revolting to me, anyway, I had a nurse coworker who had she had to have a tumor removed, and it was in her mouth area. And so when they were wanting to stimulate blood flow to that mucosa to get things to heal, they were actually putting leeches in her cheek to like stimulate where that blood was. I just can't imagine having a leech in my mouth. I don't want one on me, period, but please don't put it in my mouth. Oh my gosh, no. So that just makes you shudder. And I know we're not discussing all of the horrific things of surgery in this podcast, but it's coming. Let me just give you a little, a little teaser. However, yeah, right. But it just makes me just cringe to think about the leeches and using them on your body.
Okay,
how far we've come.
Yes, exactly. So speaking of how far we've come, then, what is it that we see in the OR that we are typically using when we're doing surgery?
So there is a wide variety of blood products and hemostatic agents out there that I'm sure everyone has probably seen in the OR at some time. So things that were most common, then we're probably most familiar with, would be like your packed red blood cells, which is the whole blood that comes, in a package. We have platelets. We can use fresh frozen plasma. We can use cryoprecipitate. You might hear that kind called cryo for short. There's albumin. And then there is another kind of, it's more of a medication. It falls under medication, but it is used for hemorrhaging effects. There is a drug out there that is a prothrombin complex concentrate. You might hear that PPC for short, or you might hear it called Kcentra medication that's out there. So those are 6 or 7 very common products used in the OR for hemorrhaging, or, sometimes you have to give blood preemptively to avoid, if you're kind of anticipating a big blood loss. Sometimes we'll just go ahead and preemptively give somebody a unit of blood before surgery just to kind of keep those levels where they need to be.
Lindsey, I think it's those of us who are in the operating room all the time, we're used to all of these different products being used and knowing that they're in our wheelhouse if we need them. But when I talk to family members and friends that know that they're going to possibly need a transfusion during an operation and have to consent to them, their minds are blown. They just see red and think blood. And so, maybe we could give them an overview of what these different products are actually doing. There's a difference when you need to give somebody packed cells versus just, frozen plasma. Could you maybe just give a little summation as to what those different products are doing for the patient?
Yeah, absolutely. We'll start with the packed red blood cells. Like you said, that's kind of common knowledge, what everybody knows, or, you see the American Red Cross is always calling for blood donations, either during a time of emergency or getting ready for like an upcoming cold, winter season. So packed red cells, are typically given when somebody's hemoglobin or hematocrit, it could be either level, are kind of lower than what they should be. So, there's been an excessive amount of blood loss. So packed cells are going to be given to increase those levels. You lose blood, you're losing sense of oxygenation to the body, not, so then you're potentially losing oxygen to all your vital organs. So the blood replacing packed cells to increase hemoglobin hematocrit, it's going to increase your oxygenation to the body as well. Another really common product that's given in surgery is platelets. So platelets are used to treat coagulation deficiencies. So a low platelet count, a PT or PTT INR are low or off levels. So platelets' main job is to help form clots and stop bleeding. So, you're going to lose some platelets when you're losing blood as well. So if we can replace platelets, we're going to, again, increase those levels and increase the body's ability to clot and to stop any bleeding occurring in the body. Fresh frozen plasma is another option that can be given, not given as commonly as packed cells and platelets and the other products we're going to talk about, but it too can be used to treat coagulation deficiencies when platelets alone are not working. Many times you can see platelets by itself being given and it works, which is great. One less thing we have to give our patients, but sometimes the platelets need a little bit of help to get those levels back up, get the clotting, it just needs a little stimulation. So sometimes we can give FFP in addition to platelets and packed cells. And I should mention too, real quick, you can give all of these products together. It's not like you can't give a platelet, but you can give platelets, but you can't give FFP, or you can give packed cells, but you can't give cryo. You can give all these products together since they're all typically typed and crossed based on the patient. So it is okay to give everything together.
And you have done that several times, I'm sure, during cases, right?
Well, it's funny you mentioned that. 3 days ago, I was on call for CVOR, and we got called at about 11 o'clock at night for an aortic dissection. And yes, later in the case, I think I gave everything but one of these products. Yeah. The only thing we didn't have to give was FFP, actually. Everything else we did give. So.
Yeah. And you had a good story, right? Like the outcome.
Yes, we were very, very fortunate. This was a younger patient with this dissection, but very fortunate that was off post-call, we were off the next day since we had worked all night. And when I went to work yesterday, I was able to go check on him, and he was sitting up in a chair, eating ice, looked amazing. Didn't remember me, which I don't take offense to, but up in a chair, eating ice, that's what makes me love what I do, despite having do it on no sleep or, have to change plans.
Right.
It's wonderful to see the outcome like that.
Yeah, especially in the operating room. As a surg tech, we never get to see the outcome of our patients are drugged. So they don't even know we exist 95% of the time. So anytime you get that kind of reward at the end to see that they're doing well, it's just, it kind of reinforces why you do what you do. So I'm so excited you got that.
Yeah, it's really a good feeling too. So,
that's awesome. What was the other drug? Yeah, what was the other drug that you mentioned?
Yeah, so there's 3 other things. So one other product that you can get from the blood bank is called cryoprecipitate, which we, for short, you'll hear it as cryo. The other packed red cells, platelets, FFP, they can come from anywhere from about 200 mils to 350 mils, depending on how your blood is processed in your area and what your local blood bank, how they set it all up. Cryoprecipitate is a little bit different. It comes in units. So you're either going to give 10 or 20 units of cryoprecipitate, and it's actually only about 10 mils of liquid once it's frozen.
Oh, that's a lot smaller, right?
It's a lot smaller, but it is extremely potent and works very, very well. It too, like the platelets and the FFP given for kind of low fibrinogen, low coags, when maybe platelets alone or platelets and platelets and FFP don't work together. This usually kind of is the next modality to get it going. And then, like I said, you put those platelets, FFP, and cryo together, they kind of then start working all together, and that's how you really are going to get to the body to start clotting.
Thank goodness.
Thank goodness. Because then that keeps us there for a long time when things are still not bleeding, or things are bleeding. So the last 2 that I'm going to talk about, you actually can get from pharmacy, but are actually used as hemostatic agents. So the first one people might have heard of is called albumin. We have albumin in our bodies already. That is actually a level that we can measure in basic blood work. So it is a protein that's found in the plasma. Albumin helps keep fluid out of our blood vessel system. So it's used to treat hypovolemia that you usually will see in hemorrhage, either like in major abdominal trauma, cardiac trauma, just something where you're starting to lose a lot of volume.
Yeah.
Because the more volume that the patient obviously has, the more increased ability to stop bleeding. It's typically given by IV. It comes in either a 5% or 25%. You can get these bottles from your pharmacy, and 25% usually is the therapeutic dose that you're going to see. And then the last product I want to talk about kind of is a real godsend, I have to say, that I've seen work dramatically and extremely effective and quickly, is a product called Kcentra. It effectively reverses the effects of blood thinners. So sometimes during surgery, not just cardiac or vascular where you're thinking about having to give heparin. There's other instances where you may have to give heparin to a patient.
Right. You're trying to prevent clots. Yeah.
Yes. Yep. Trying to prevent clots. We need to reverse that heparin at the end of the procedure. So we usually will give the agent for heparin reversal is called protamine. But sometimes protamine is not very effective, especially in, again, trauma patients, critical cardiac patients, when the body's already at like major distress and it doesn't know what has just happened to it. So sometimes in addition to protamine, we will give this product called Kcentra that will just help kind of increase the effects of protamine to help stop bleeding. It usually is a weight-based drug, so you do need to know your patient's weight in kilograms so the pharmacy can concentrate it according to the needs.
Yeah. I would imagine in all of these instances, at least when I worked CV back in the day, like everything has to happen so quickly because if your patient's hemorrhaging, like time is of the essence, right?
Yep.
And
yes.
Yeah. So your communication as an RN with the pharmacy, not just with the OR staff and anesthesia, but your communication with pharmacy has to happen so quickly. And all of that information you're communicating has to be on point because these medications are weight-based. Yeah, that's just so critical. I think that's another one of those kind of like teamwork issues that people don't understand is occurring in the middle of all of this trauma, especially in the middle of the night too.
And you're constantly communicating with the blood bank as well.
Yeah.
Like, that's usually when I come in on an emergency case, that's probably one of the first or second calls I'm making is to the blood bank is, what do you have on this patient? What's available? Because products like the fresh frozen plasma and the cryoprecipitate, those need like 20 minutes to thaw. Those are kept frozen in the blood bank, and time is of the essence. So sometimes I will call as soon as I even think that we might be needing something. Because once you thaw it out, it has to be used, or unfortunately it gets wasted. So the minute we know that we're going to potentially need something 30 minutes from now, we're calling and giving them it. Sometimes we're even calling and giving them a heads up that, hey, we need this product, start thawing it now, and then I'll put the order in. Just any little thing to kind of cut down on that. So it is a lot of communication. And again, we're talking about typing, making sure the patient is correctly typed and crossed, make sure that the blood bank has the correct typed and crossed products as well. But sometimes time is of the essence and you just have to go. So sometimes we do have to give uncrossed matched blood to a patient. And it is a risk for sure, but again, time of the essence, life is on the line. We just got to give them volume. We just got to give them something.
A lot of times that's your code gray blood, isn't it? I mean, less the facility. That's what we call it at our facility was code gray.
Oh,
So, but that was the blood that they kept on hand in an emergency situation. We didn't have time. We just had to give these patients the blood that they needed. And so it was our code gray blood, and it was available in the lab for an emergency.
Wow. I've never heard it called that before.
Okay, where do you have it?
We call it a massive transfusion protocol.
Oh, that's very official.
Oh, yes. And then that essentially gives us like 6 units of uncrossed matched blood and like 4 units of uncrossed matched platelets and 2 units of uncrossed matched FFP. I will say sometimes I've had to give uncrossed matched blood in the past, and fortunately the outcomes fared in our favor. But I feel like sometimes when we've called for massive transfusion just to have something in the room, blood bank is very effective, and the lab as well is very effective and working very quickly to make sure that they get that type and cross as quickly as they can, and then they're getting that blood to us as quickly as they can. Because blood bank necessarily doesn't want us to give uncrossed matched blood either.
Sure. And just for education's sake, the blood that we give in an emergency situation that is not cross-matched, what blood type is that?
It is O negative.
That is correct. Very good. And understanding those blood types and who gets negative and who gets positive and who gets O, A, B, A, it can get really confusing, and that's a different podcast all in and of itself. But in an emergency situation, our patients are getting that O negative blood. That's the blood that we can get for our massive transfusion protocol or our code gray, as the case may be.
Or our holy crap.
Yeah. Holy cow, we need blood.
Oh, I like that better.
Yeah, absolutely. Well, and I love always that not only are you all communicating with all of these other departments, but once that bag comes into the operating room, we are doing cross-check after cross-check after cross-check with the numbers and the patient identification and all of that. Maybe speak to that process too, because, that's an internal double check that we're doing that people don't witness outside of the operating room.
Yes, absolutely. So at a lot of facilities, the blood is, whoever goes and picks up blood from the blood bank, that is checked between the person in the blood bank issuing the blood and the person who is picking it up. Again, like you said, brought to the room. And once in the room before it is transfused, it has to be checked between 2 licensed providers. So 2 nurses, nurse anesthesia. In cardiac cases, it can also be like the perfusionist as well. So yes, like you said, Chris, we're checking name, date of birth, medical record number. A lot of places, if patients are typed in cross, they have a separate blood band number as well that's assigned to them for their stay. We're checking what the product is. You're checking that the patient is O-pos and the product is O-pos, for example, on packed red cells. We're checking the unit numbers. We're checking the expiration date. We're even checking to make sure that the temperature of the bag is at a safe temperature as well. Packed cells have to be kept cold at all times. And our facility actually have boxes that our packed cells can come in with ice packs. And they actually are FDA approved to keep the blood in these boxes in the room cold for up to 8 hours, which is great because that's perfect. It would be luck that you get your product in the room and you're not going to need it. And at 4 hours, you have to send it back. And at 4 hours and 10 minutes, you need that blood. Platelets can be kept at room temperature. And then usually anything frozen, like I said, is frozen and then given immediately. Then you always want to make sure and patients have at least 2 IVs coming into surgery regardless. That's usually not a problem because they will use one IV just for blood and blood transfusions as needed, and the other IVs typically for medications.
So much forethought goes into it before the patient's even cut on, which is a good thing because you just never know. Yeah.
Safety is key when it comes, because while not technically a medication, we are giving a product to somebody that can cause a serious reaction. The CDC regulates and monitors the blood supply in the U.S., and the FDA actually oversees the safety of blood products and transfusions that occur in the United States. And then there's all other kinds of agencies that are involved when it comes to blood safety. The World Health Organization, the Association for Anesthesiologists. There's the Association of Blood Banks. There's the Society of Cardiovascular Anesthesia. They all have statements on the administration and indication of blood products and blood safety administration.
Awesome. And rightfully so.
For sure. We have covered a lot of information in a very short amount of time. And it's always a pleasure to actually get to sit and talk to you and hear about the things that you do and learn from you. And as we wrap up, is there anything else that you want to cover before we end this interview today?
So I think the one takeaway I want to give everybody is, regardless of what specialty you may work in the OR, never think as an OR nurse that you will never give blood products just because you work in a specific specialty. Blood products can be given, you think about cardiac, vascular, trauma, even, major ortho, major neuro. Anything can happen at any time in any case, regardless where you're working in the body. So never think that, I work in ENT. I'm never going to have to give any type of blood product. That's not the case. It's more common than obviously in those other specialties, but you need to be prepared. You need to know what's out there. You need to know what's available. You need to know who you can call, maybe even if you're not sure, besides just your charge nurse. Like I said, I work in CV and we get called from general OR all the time. Like, how do you order blood? I don't even know how to order blood. What do I need to order? So that goes, and think about your hemostatic agents that's out there as well that you could be using in addition to blood and blood products. If you're in a critical, chaotic situation, people might be thinking one thing, and then you could say, hey, what if we use this as well? So kind of always keep that in the back of your mind that there's, products in your OR to use. We all learned about blood administration in nursing school. So this kind of goes back to your basic nursing knowledge.
Mm-hmm. For sure. But it's always good to have a refresher and have a reminder. And when we get in those emergency situations, we need to fall back on our muscle memory and our brain memory, because when we get flustered, we don't always think straight. So, Lindsey, thank you for joining us today and for being a guest on the show. Really enjoyed it.
Thank you for having me.
Lindsey Joyce talking all things blood products today. And like we said at the end of the interview, when you're in an emergency or a trauma situation, we can get flustered, and it can be very difficult to think clearly sometimes in the heat of the moment or the stress of the situation, which is why it's so helpful to have conversations like this one when a patient isn't actively bleeding to death, so that we can think through what we have, what we need, what might be needed in a situation. And, Chris, I really think Lindsey gave us a really solid overview and some really good insights that we can pull from the next time we might find ourselves either maybe routinely just having to give blood, but also maybe in the event of emergency as well.
Yeah, absolutely. And just to hear how important communication is, not just between the OR team, but also within all of the other departments that are involved, is so important. And as much as I love reading everything that Lindsey writes for First Case, it was so much fun to actually hear her talk about something she's so passionate about.
Yes, always great to have her in the studio to join us and to actually feel like she's really part of the team talking with us on the podcast. So that is all the time that we have for today. We've still got more to come this season, so stay tuned. On behalf of Chris, Lindsey, myself, and the whole team here at First Case, thanks for listening to this week's interview.
Thank you for listening to this week's episode of First Case. As a reminder, you can help support us by subscribing to First Case on your favorite podcast app or by downloading the smartphone app on iPhone or Android. Simply search for First Case in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@firstcasemedia.com. We look forward to hearing from you.